So today's focus is mainly on rheumatoid arthritis and osteoarthritis, because in any field of those who are practicing medicine, not only rheumatologists but also other specialties and all general practitioners, they must come across these arthritis patients. And for the patients, the life is miserable. For their, not for the disease only, but for the treatment is also very cumbersome. It requires long-term medications and which has significant side effects also. So rheumatoid arthritis, as we know, is a systemic disorder characterized by chronic inflammatory polyarthritis of unknown etiology. The inflammatory states also involve skin, eyes, lungs, and blood vessels. And fluctuating clinical course and unpredictable prognosis associated with 60% increase in the risk of CVD related. This is important. And complex and multifactorial pathogens.
In a key step, activated macrophages and synovial fibroblasts release pro-inflammatory cytokines, including TNF-alpha, IL-1, and IL-6, and mediators of vascular growth, including VEGF. VEGF is essential to the process of blood vessel proliferation, or angiogenesis, which facilitates an influx of activated cells. These cells contribute to the growth of pannus and sustain the inflammatory cycle. The growing, vascularized pannus develops villous projections that result in better access to the cartilage and bone, and therefore greater opportunity for the activated cells to release damaging inflammatory mediators and enzymes. In the interface between pannus and cartilage, activated synovial fibroblasts and macrophages are a source of enzymes that degrade the cartilage matrix. These include MMPs or matrix metalloproteinases. Thus, activated cells in pannus are key instigators of cartilage destruction. Chondrocytes are the main cellular component of cartilage and normally produce the extracellular matrix. However, in response to stimulation by TNF-alpha, IL-1, and other inflammatory mediators, chondrocytes become activated in the rheumatoid joint. Activated chondrocytes secrete more inflammatory factors and more metalloproteinases, MMPs, which aggravates inflammation and cartilage damage. The cumulative result is irreversible cartilage damage and joint space narrowing. Under normal conditions, bone remodeling involves a tightly regulated balance between bone resorption and bone formation. However, excessive TNF-alpha helps stimulate osteoclastogenesis and bone destruction. In the marrow, TNF-alpha helps stimulate monocyte differentiation into osteoclast precursors. At inflamed joints, in the presence of macrophage colony stimulating factor, TNF-alpha, and rank ligand, osteoclast precursors differentiate into mature osteoclasts, resulting in bone resorption. Thus, the direct and indirect effects of the TNF-alpha on osteoclast maturation and activation culminate in focal bone erosions and irreversible joint damage.
So you have seen how the inflammation causing cartilage damage and the bone destruction. Next is the pathophysiology of osteoarthritis. Here also TNF-alpha, interleukin-1 are the major cytokines involved in the pathogenesis of osteoarthritis. Apart from TNF-alpha and interleukin-1, elevated levels of interleukin-6, interleukin-17 and matrix metalloproteinases have also been shown to be implicated in osteoarthritis. That leads to synovitis, articular cartilage damage, and in both, if you look at both RA and rheumatoid arthritis osteoarthritis pathophysiology, the TNF-alpha and interleukin-1 are the major inflammatory cytokines involved in RA as well as osteoarthritis. The release of these inflammatory cytokines is regulated by nuclear factor kappa B. The nuclear factor kappa B is a transcription factor present in all cells, and nuclear factor kappa B plays an essential role in inflammatory and immune responses. Nuclear factor kappa B as a master switch to turn inflammation on and off in the body. Due to nuclear factor kappa B activations are rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, psoriatic arthritis, and juvenile rheumatoid arthritis. Now, an innovative option for management of arthritis. and to block the master switch, the nuclear factor kappa B inhibitor is being tried. The molecule is curcumin, which is diphennyl methane, the biologically active phytochemical compound obtained from the rhizomes, Curcuma longa, and possesses diverse properties. It has anti-inflammatory, antioxidant, anti-proliferative, and anti-angiogenic. That controls NF kappa B as a master switch of inflammations. And it has multiple site of actions. You have already shown these slides, I am not speaking. Now, what is the clinical evidence of curcumin, that is its role in rheumatoid arthritis and osteoarthritis? Here is a study on rheumatoid arthritis, the comparative study of curcumin with the diclofenac, the non-steroidal antidote. Curcumin provided better improvement in disease activity score and ACR scores as compared to diclofenac, and there is 52% reduction in C-reactive protein levels with curcumin. And this comparative study with curcumin and curcumin with diclofenac shows significant reduction in all the like painful joints, total solid joints, patient global assessment, physician global assessment, disability index. And another evidence of rheumatoid arthritis is a pilot study of curcumin. 18 patients with rheumatoid arthritis were treated with curcumin for 2 weeks. The curcumin improved joint swelling, morning stiffness, and walking time. Curcumin was very well tolerated and better GI tolerability. So curcumin is effective and well tolerated in treatment of rheumatoid arthritis. In osteoarthritis, there is also evidence, real life experience with curcumin monotherapy. 820 patients of osteoarthritis attending outpatient clinics were treated with curcumin for 6 months. Curcumin therapy provided significant improvement in pain, improved joint flexibility, and better quality of life. 50% of patients were able to discontinue use of NSAIDs and analgesics, and curcumin therapy was very well tolerated. So curcumin relieves pain and reduces the need for NSAIDs in osteoarthritis. In comparative study of curcumin with ibuprofen, 367 primary knee osteoarthritis patients with a pain score of more than 5 were randomized to receive ibuprofen 1200 mg per day or curcumin for 4 weeks, and the results were all comparable. The significant decrease in WO max pain, stiffness, and function score from baseline in both groups. Curcumin was found as effective as ibuprofen, and lower incidence of GI adverse effects in curcumin group. Curcumin is as effective as NSAIDs, but it has better GI tolerability. And role of curcumin as monotherapy in osteoarthritis. 100 patients of osteoarthritis were treated with curcumin for 8 months, and significant decrease in serum inflammatory biomarkers like interleukin 1 beta, interleukin 6, soluble CD40 ligand, soluble vascular cell adhesion molecule 1, and ESR, and more than 50% decrease in OMAC score and 3-fold increase in the treadmill walking performance. In patients already on NSAIDs and analgesics, required administration of curcumin was associated with decreased need for NSAIDs and marked reduction in GI side effects. The curcumin is effective and safe for long-term management of osteoarthritis. In another study, the evidence, the combination therapy curcumin with diclofenac, 88 patients with primary knee osteoarthritis were randomized to receive diclofenac alone or diclofenac with curcumin for 3 months. As compared to diclofenac monotherapy, combination of curcumin with diclofenac was associated with greater pain relief, better improvement in knee injury and osteoarthritis outcome score. So in conclusion, curcumin was, when combined with NSAID, provides additional benefit. So in combination therapy, curcumin when given along with celecoxib enhances action of celecoxib on COX-2 and decreases need for celecoxib. Curcumin when given in combination with prednisolone provides additive anti-inflammatory action to inhibition of inflammatory cytokines, significant reduction in joint swelling, and reduction in side effects due to steroids. Curcumin when administered with methotrexate provides synergistic anti-arthritic action, may also help to reduce the dose of methotrexate and reduce risk of hepatotoxicity and hematological toxicity. So what is safety of curcumin? The curcumin is generally recognized as safe drugs by US FDA. No noticeable adverse events were observed with doses up to 8 grams daily for 3 months. Unlike NSAIDs, free from adverse effects on kidney, liver or cardiovascular system even after long-term use. An occasional patient may complain of mild and transient nausea or diarrhea. So unlike NSAIDs, steroids and DMRDs, the curcumin is very well tolerated. So now there is novel formulation of curcumin. Why it is needed? The conventional curcumin, there are some limitations. This is very poorly water soluble, polyphenolic compound, poorly absorbed from the GI tract, undetectable in plasma, doesn't reach systemic organs and tissues, so efficacy is questionable. The clinical trials carried out with conventional curcumin have used high dosage up to 12 grams per day. Few studies have not shown positive results and there is poor GI tolerability. So need for a bioavailable, effective and well tolerated curcumin formulation. To overcome limitations of conventional curcumin, novel formulation of curcumin using self-microemulsifying drug delivery system has been developed. So this technology provides nano-sized hydrophilic droplets of curcumin, improved absorption and better tissue penetration. So bioevidence in human pharmacology studies there, and the more the dose, the plasma concentration is initially high, but later it's smoothed out, and this formulation enhances higher, ensures higher bioavailability. And bioevidence curcumin doses, the exact dose may vary from patient to patient, depending upon the disease severity, degree of inflammation and patient response. Majority of the patients with mild to moderate inflammation usually respond to 100 to 200 milligram per day. If required, one can increase the dose up to 400 milligram per day. In summary, the curcumin inhibits the master switch of inflammation, that is NF-kappa B. Decreases release of inflammatory prostaglandins and cytokines, prostaglandin E2, TNF alpha, interleukin 1, interleukin 6 and interleukin 8. Monotherapy found to be effective and safe in treatment of rheumatoid arthritis and osteoarthritis. Efficacy at par with NSAIDs but with better GI tolerability. Can be used along with NSAIDs, steroids and provides additive and synergistic action that helps in dose reduction of those toxic molecules. And can be used along with methotrexate, helps reduce the risk of hepatotoxicity. Unlike biologics, can be given orally, is safe and well tolerated. So suitable option for monotherapy as well as combination of both options are also addressed. An attractive option in management of rheumatoid arthritis either as monotherapy or combination therapy. Particularly useful option in the following group of patients: intolerant to NSAIDs, steroids or DMRDs, compromised renal function, hepatic dysfunction, CV disorders, hypertension, congestive heart failure. It can be used. It is effective, safe and well tolerated treatment options. Thank you.